So we will discuss in these 7 points the choosing of the candidate for the contact lenses, and at the same time we can discuss about the contraindications, and then the types of contact lenses available, and assessments for fitting and prescribing contact lens, and delivery of the contact lens, after sale service, and little bit on touch of the complications. Now refractive error is the main concern. So if you look at myopia, hyperopia, astigmatism, irregular astigmatism, presbyopia, and all types of lenses varied based on the refractive error. Though there are limitations, like now if you decide, like as an example, if you are going to use the disposable contact lenses, the 2 weekly disposable contact lenses are only available up to -9. A monthly disposable is available only up to -12. So all the other refractive errors can be covered with different kinds of contact lenses. So then after the now when we look at the refractive errors, the second thing that we look at is the corneal assessment. So we have to take at least a keratometry reading before fitting a contact lens. And if topography can be taken is better, but without a topography sometimes we can fit a contact lens if it is not a very complicated, like if it is not keratoconus. So K reading is good enough to do the contact lens. Then the base curve. Not like glasses, the main thing in the contact lens is the base curve, the curvature that fits on the cornea. So actually contact lens, what does is that neutralize the eye, whereas the glasses, it neutralize the light. So light entering the eye is neutralized by lenses in the glasses, but what contact lens does is contact lens neutralize the eye. So the main concern and main part of the contact lens is to get the right base curve for the contact lens. So then we measure the horizontal visible iris diameter, and then the power, the refractive power is the fourth thing. And then if we can take the corneal thickness and endothelial cell density, it's better. For the special cases we do that, but for the basic contact lens can be fitted with the K reading and horizontal visible iris diameter and the power. So the third one is that we have to look at the corneal adnexia, where the tear film is very important, because contact lens don't sit on the cornea. Contact lens sits on the tear film of the cornea. So tear film is very important. If a dry eye or dry eyes, things like that is there, so if the tear film deficiency or bad quality tear film, so we don't recommend giving contact lenses. And these lid margins has to be very nicely, there are no injuries, no blepharitis and things like that. Then the hygiene, like general hygiene, like sometimes the patient has to handle the contact lens, and the general hygiene has to be there in the eye, and then generally in the patient. Then they should be free of ocular pathology. And then sometimes if the low motivation is a contraindication, sometimes their friends are wearing contact lens, because of that they come for contact lens. But sometimes, because, like say as an example, if a keratoconus patient wants to one eye 6'6" or 6'9", the other eye 6'12", 6'18", so if we push for the contact lens, and then with the glasses, if they have 6'6" in one eye and 6'9" in the other eye, we should not push the patient. So there should be motivation from the patient side to have the successful fitting of the lens. So other things, we look at the history of the patient, whether he has used contact lens before, and with that they have bad experience, why it has been happening, and if they had have some infections with the contact lens, so we look at that. So the other one is the where the patient is working from, where are they coming from, and things like that. It's also important in the fitting of the this kind of some disabilities in the facial asymmetries and things like that is also as a problem. And we have to, in the first go, before giving the contact lens to the patient's handling capabilities is also important. So sometimes we have a workers who is coming with -8, -9 refractive errors, but their hands are not very clean. Like I had the three-wheeler driver, the finger that they are going to use the lens is bigger than very very big, and then little dirty. So those kind of people, it's very difficult for us to give, or manual workers who can't handle the lens proper. So we should not encourage. And at the same time, sometimes it's the other way around. So there are people who has never used a broom or anything at home, so they cannot handle the lens. So before giving the lens, we have to look at that side as well. Then other thing is, like, some of these lenses are expensive. So method of choice these days for contact lens is monthly disposable. So monthly disposable will cost about 50,000 rupees a year. So for if someone who can't afford, so if we go and push them for lenses, so it's ended up having problems. And the last thing is they should come for the follow-ups. The patients are coming from very far and they can't come for the follow-ups. So that also we consider when thinking of giving the contact lenses. And second point is the type of contact lens available in the market. So there are two types of contact lenses available. So the soft ones, there are two types. The conventional soft is the cheaper one, which is the one was there before, and the other one is what we call disposable, or the right name for the disposable is the program replacement. The disposable means like you wear in the morning and throwing out are the daily disposables, which are very very expensive. So other lenses are called program replacement systems, where you use the lens in the morning and remove it and put in the case. So some are for 2 weeks, some are for 1 month. And then conventional is what we use for 1 year, through one year. So you wear it in the morning and remove it, and you use it for 1 year. So hard ones are mainly two types. PMMA is the older version, which is not being used now, but still we have few patients who are using PMMA lenses. Especially the Japanese companies still make the PMMA lenses. And RGP is the one is mostly used for keratoconus and things like that, the irregular corneas. And then the hybrid is partly soft, partly hard lenses. And you have to choose which lens fits to now see what is the best lens for the patient. So that is why I put this slide. And in the soft lens, I put here some materials that we use. The most common one is it's a hydrogel lens, or the conventional lens are called hydrogel, and it's made out of different material. And then the silicon hydrogel are the newer materials, are mostly used in disposable or the program replacement lenses. And HEMA is also used for conventional contact lenses. So these are few materials I just put in this thing. Then hard lenses, there are so many materials available. So they are plastics. They are PMMA is the best biodegradable material available. But the others are all the mixes of silicon and mixture of silicon and plastics. And you look at the slide on the side. The soft lens sits on the iris, on the sclera. It covers the whole iris. It sits on the cornea. Whereas in the hard lens or the rigid lens, it sits on the cornea. We call it corneal contact lens, and the soft one is bigger and it sits on the sclera. So for the presbyopia, also we have so many varieties of contact lenses. So there are bifocals, this different types. I think I don't want to go into detail now. Just like the multifocal intraocular lenses, these are also different types of lenses available. And most commonly used are the bifocals and diffractive multifocals. Then we have specialty contact lens. I have some samples. You can pass it. No? You can pass around. And now in this one, you see this as a prosthetic contact lens. This is a white eye. So this is here after fitting the prosthetic lens. These prosthetic lenses are also available. And these are X-chrome lens, where the color vision deficiencies, we can use this X-chrome lens. It is not very not 100% successful, but there's like you can get some sort of a color vision with this lens. With our dark pupils, this red lens is not visible. Sometimes with the lighter color of the lighter pupil colors of the eye, so it's little visible, but with dark pupils it is not visible, so you will have a decent color vision. And these are cosmetic. We don't recommend it very much, but it's becoming the fashion now, so we will get lot of problems, I am sure, because overwearing. So what we recommend is 6 hours, 8 hours a day for 30 wears within 3 months, but people don't go for it, and their oxygen permeability is not very good. We usually don't recommend, but there is a big demand and lot of youngsters using these lenses. So the next point is the assessment for fitting. So this is a basic contact lens. In any contact lens, you have the center piece, which is called optic zone, and then secondary and tertiary curves. So 3 curves in most of the lenses, but the newer lenses, more comfortable lenses, has so many curves. So at least three curves. So the base curve is what is in the optic zone curvature is called the base curve. So this is the diameter. So choosing the trial lens. So when we decide on the base curve, then we decide on the refraction, and then we look at what's the horizontal visible iris diameter that we are going to decide on, depending on the corneal parameters. So as an example, I get few examples here. So this one, the K reading is not like refraction. We are talking on the millimeter numbers. So this has a 7.46 horizontal K reading and 7.31 vertical K reading. So, and the patient has minus 150 refractive error. Horizontal visible iris diameter is 11.2. In a case like that, so the trial lens what we have is minus 3. Now here we can if it is a disposable one, we can use minus 150, 8.6 and 14.2 diameter. So those are from the available stocks. Now like 14.2 is the diameter. So the cornea is 11.2 in this. In the soft lens, we need to have the full coverage. That is why we go for 14.2. 8.6 is the flattest curve in this one is 7.46. So we add two diopter, 2 millimeter, 0.2 millimeters. So we choose 8.6. So usually in the trial sets we have -3, but in this case, the lower cases, sometimes we have -1.5. If you look at the other case, we have a -3 astigmatism. So although we have -3 astigmatism, our trial lens is only -3, and the base curve is high in the flatter curve is 7.86. So we go for 8.88 base lens as a trial. So we do over refraction on this, and then get the trial frame. We will get about -2 cylinder on this case. So then we write it down, and then we make the lens accordingly. In the hard lens, now it's in the the same patient, 7.46 is the flatter curve. We fit it to the flatter curve, so we go for 7.5 is the closest trial lens, and the trial lenses are available from -3, and we reduce 2 millimeters, 2.2 millimeters from the diameter, so the diameter is 9.2. So we put this trial frame and do a over refraction. When we do a over refraction, we will end up with maybe -1.5. So if we have choose the right base curve, the refraction is a baseline for a now say if you get -2 or something, then we know we have gone wrong in the base curve. And in the other one, the same patient, we use 9 millimeters, slightly smaller, because it sits better on the cornea. Smaller the lens, it sits better. In the other way around, if it is very steep, so you need to have a bigger lens. So there the base curve is 7.85. That is the flat base plus flat base that we looked at. And when you do the over refraction on this, so the cylinder will be taken over by the tear lens. So with the lens and the cornea, there will be a tear lens. The tear lens will take up the astigmatism. So in the hard lenses, it won't take the shape of the cornea. So because of the tear film, I can't draw it. We'll go back to the tear film will take up the astigmatism up to -3, -4, and so after putting the trial lens in the eye, we ask the patient for a soft lens, about waiting for 10 minutes, but for the hard lens, the patient has to wait for about 20 minutes, and we do a over refraction. After doing the over refraction, we decide on the lens, and then we looked under the slit lamp for a corneal coverage. Now this is a soft lens. You can see the edge; it covers the whole cornea, and in the hard lens, it doesn't cover the whole cornea. It sits on the cornea, and this is the tear lens that. Oh, sorry. This is the tear lens that we are looking at. So this is the cornea, and then this tear lens take up astigmatism in the hard lenses. So the other thing, we will look at the lens movement. None of these lenses fit on the cornea. It moves a bit. So it moves a bit. The soft lens, under the slit lamp, you can see the lens moves about 1 millimeter with each blink, and then the hard lens or RGP lens moves about 2 millimeters with the movement. Like when you blink, it has to move, so it won't fit into the eye. So assessing the fitting, so you look under the slit lamp to see how the lens is moving. So the next is like what decide on all those three. When you put the lens on the base curve, how it fits on the eye, and then the over refraction, and then we decide what to give. And there, so if it is -4, this spectacle, so usually the contact lens power is slightly less. If you look at -10, so the contact lens power will be about -9. So we keep it that in mind. If everything is going okay, this is the way it should work. And when it comes to the plus, it's the other way around. If the refractive error on the glasses is 9, so your contact lens power is higher. So then after you take the prescription, then you decide to make the lenses, and then maybe on the same day if you have the lenses in stock. If not, after lens is made, we ask the patient to come in to get the lenses. So before giving the lens, we have to assess the lens ourselves, whether the lens has come proper from the laboratory, and allow the patient to wear the lens on the patient's own. So earlier we used to put the lens, but on the same day, before taking the order for the lenses, we see they have the handling. They can put the lens, they can remove the lens. Now this day they wear their lens on their own, and after 15 minutes of thing, we use the slit lamp and look at the lens movement and all that, and record the visual acuity. So if the lens is okay, so we ask the next part is not like glasses, they have to look after the lens proper. In that, when you wear the lens the whole day, the lens becomes dirty, and then we have to clean the lens after removing the lens. You clean the lens, and then there will be some germs in the lens wearing it here and there. So you have to disinfect and store. So those 3 steps for all the lenses, whether it is disposable or hard or soft, those steps are there. So for the disposable ones or the program replacement, we don't use the enzymatic cleaning tablets. But if it is a conventional lens or a RGP lens, we have to use the enzyme tablets for dissolve the proteins that build up on the lenses. And lastly, so sometimes especially with the hard lenses, patients has to use the lubricating drops. So after sale service is also as important as on the day of delivery. So we fix up the schedule. So patient has to come back after 2 weeks for the first examination, post-op, post contact lens, and then the 3 months later, and every 6 months. So this 2 weeks is it's very, very important. So we ask patients to come wear the lens, wearing it for minimum of 6 hours, and to come and see us. And on the second visits also we see the whole set of from A to Z, to see the visual acuity and do over refraction. We look at the movements and all that, and if there are any changes, sometimes we have to adjust in 2 weeks, but 3 weeks and other things just to revise now about how they take care of the lenses and all that. So I think next lecture is on this subject, so I will just finish my presentation here.